Here, next, you see, next itis we want to discuss is keratitis now. And since Dr. Somasheila has arrived and she has volunteered to be in queue for next, so I'll request Somasheila, a doyen in cornea from Hyderabad. Somasheila, we just discussed partly. You have heard about conjunctivitis, and we
Yes,
have
Dr.
had a lot of discussion on this.
Yes.
And you can now start with keratitis.
Yeah.
What
Good evening,
what
everyone.
everybody
Good
should
evening,
know and
Dr.
what
Verma.
our aim is, what everybody should know and should not miss.
Am I audible?
Yes, yes, yes. Slides we want to
Okay.
see.
So,
So to
so
share.
yeah, I'm going to share, but I'm going to just turn off the video because my bandwidth is not
Okay.
very
Okay.
good.
Okay.
So, firstly, I just wanted to say that I'm really grateful, and just like Rajesh said, that this is a really unique webinar on itis, and I'm very sort of excited and pleased with the title actually. So the itis, what everyone ought to know. My topic being the keratitis. And also, although I was operating I was logged in, so I was listening to the entire conversation. And I was listening to the very interesting discussion on conjunctivitis. And so now we move on to keratitis. I thought that I'll try to keep it more succinct in the scope of trying to finish faster so we can have more discussion. But just to bring in the importance of the topic, so it is estimated that there are approximately 10.6 million corneal blind in India in the year 2020. And of these corneal blind, at least 50% could be due to active keratitis or childhood keratitis or corneal scar. Dr. Verma, am I audible?
Yeah, you are audible, audible.
Yes.
Yeah, yeah.
In case you lose me,
Yeah,
can
yeah.
you please call me because I
Yes,
have
yes,
no way of
yes,
knowing.
yes,
All
yes,
right. Thank
yes.
you. Yeah, so at least 50% of these are due to active keratitis or due to childhood keratitis or corneal scar following keratitis. That means there's a huge scope for the itis part of it, why people are blind due to corneal disease. And obviously, if we can somehow treat microbial keratitis very early on, we can avoid the condition of blindness. So that is the importance of keratitis. And just to also tell us about the kind of organisms we see in most of the developing nations, including India. So bacteria sort of takes a precedence based on the study about maybe less than 50% in South India. As you go towards North India, it's a little higher. And for us, in our LVP data, we also saw about just over 50% was bacterial. And therefore, fungal and other organisms took up the remaining. Most of the chunk was due to fungal organisms. Having said that, fungal infection is more likely to cause blindness as compared to bacterial because we have more early recognition and better antibiotics, I would say. And then there are rare organisms also. So we all know this. This is what we know already, that we should very carefully examine a patient who comes in with microbial keratitis because it is a medical emergency, it is sight-threatening. So we take great efforts at looking at the onset, how was the progress, what has the patient received, and was there any response or not. In addition, we would also look at other things such as history of injury to the eye, some foreign body falling into the eye. Is the patient using contact lenses? Recent surgery, anything related to cataract surgery or a corneal transplant? And is the patient systemically unfit as an immunosuppressed or any other such disease? One more very important component which we know, we already know, but we ought to know and ought to do more and more often is to check for other contributory factors, such as does the patient have corneal anesthesia? Is there a tear film problem, as in there's an ocular surface disease or dry eye? Is there nasolacrimal duct obstruction? I'm mentioning these because you cannot imagine how frequently we see patients where these things are missed, and that's the reason why they get predisposed to infection. Simple things like entropion, tracheitic eyelashes can also cause secondarily the epithelium to abrade and then infection, and sometimes missed foreign body. So what we know and ought to know and ought to do is in this slide is mainly to examine and see if there's any other reason that the patient got the infection and address that first. So I'm going to divide this talk after the introduction into three segments. The first one is about commonly encountered infection. The second one is uncommonly encountered infection. And lastly, I'll just touch upon non-infectious keratitis. I'll try to keep everything very brief. So bacterial keratitis is commonly encountered. Almost every ophthalmologist in practice must have come across at least one or two cases, if not more. So it can be as mild as this. All of these are gram-positive cocci. It can be as mild as this. It can be as bad as this. Or it can look very different with these satellites and so on. Or it can be after cataract surgery. Here's ECC and there's a gram-positive cocci infection for this patient. So many of these cases could be missed nasolacrimal duct obstruction cases. So you have a blocked sac and then there's infection and that's why they get this. So look at the NLD in these situations. Then you can have gram-negative bacilli. You know that they can be devastating. They progress very rapidly. Sometimes you can be lucky and just have a minor or sort of a peripheral infection, or you may have seen patients who come in with this kind of infection and within no time, maybe 12 hours even, they go on to this perforation stage and endophthalmitis and panophthalmitis, and you're left with no choice but to eviscerate. So that is about gram-negative bacilli. So in bacterial keratitis, should we use empirical therapy or should we use protocol-driven therapy? What we ought to know is that empirical therapy means that we use broad-spectrum commercially available antibiotics. Typically, fluoroquinolone is used, moxifloxacin, for example, as monotherapy. Or should we use protocol-driven therapy, meaning that we do corneal scraping and then we use a combination of fortified antibiotics, which covers gram-positives as well as gram-negative. So sometimes it's difficult for a doctor practicing on their own or in a remote place to have access to microbiology. Therefore, sometimes you have to make a hard choice. Should you use monotherapy or should you use fortified antibiotics? So this is already well described and published in literature that if you have a smaller, less severe, non-vision threatening ulcer in the periphery, for example, this is not exactly in the visual axis, it's just off the visual axis, it clinically appears bacterial. It may have had a rapid onset and progression. So we can start the patient, if there is no other resource, we can start the patient on broad spectrum 4th generation fluoroquinolones, such as moxifloxacin, or on our own, we can start the patient on fortified antibiotics and observe for the next 12, 24 to 48 hours. But beyond that, we should not wait. Beyond 24 to 48 hours, if there's no sign of improvement, it means this patient is not going to improve. Whereas in the case of severe keratitis, we cannot do empirical therapy or we cannot just use fortified antibiotics on our own. Why? If this is gram-negative, it may be resistant to the routinely available antibiotics. So even though there's a good combination of fortified vancomycin and tobramycin or ciprofloxacin, and we can initiate therapy every 1 hour, but this kind of patient will have to be evaluated back in 6 hours and then back in 12 hours. And the best therapeutic goal that we can achieve is actually using microbiologically guided therapy. This patient can improve very well. You can have only a small sort of not small, but more superficial sort of an anterior stromal scar. You can restore vision even with the help of a contact lens for this kind of patient if treated appropriately. So for this kind of patient, I would frown upon empirical therapy. This patient should be referred and should go in for a more robust therapeutic regimen. So to capitulate, the management of non-site threatening ulcers, when I say non-site, I mean the peripheral ones. They can explode and become site threatening. But you do a careful clinical examination, rule out other causes, can start empirical therapy, re-evaluate. If they're getting worse, then you have to send the patient for microbiological evaluation at whichever center available, and the treatment must be changed accordingly. In the case of site-threatening ulcers, cut to the chase, corneal scrapings, and the treatment based on smears, followed by culture sensitivity, and change treatment. If nothing works, then you have to go with surgical intervention. So second part of what we must know about commonly encountered infections includes fungal keratitis. This accounts for 40 to 50%, where many of us are familiar with this ugly sight of patients coming in with history of trauma, sometimes rapidly evolving, or sometimes maybe a more insidious history to have the entire cornea infected like this. They have the feathery hyphate extensions. It can be, as in this example, it can be aspergillus like this with injury with the vegetative matter, or it can be fusarium. In this particular case, again, there would be injury with vegetative matter or some other foreign body, like this patient had cement falling in the eye. But along with fungal keratitis, what we must know is about the uncommonly encountered infections, because there are plenty of them. Although we say they're rare, but because we are a large country with a huge population, so when you look at just the numbers, even an uncommonly encountered infection, you may encounter as you keep on seeing these infections. What are these? So by all means, this patient looks like fungal keratitis. There's this fluffy looking sort of dryish, fluffy looking, grayish exudate with sort of high feet or spreading edges. And it's getting close to this limbus, but it looks more superficial. So we're not very alarmed. Yeah, it looks like fungal, and we know what is the treatment for fungal keratitis. Patient also is a farmer history of injury to the left eye, with vegetative matter. So, you know, in fungal keratitis happens like this, but it's not fungus. It's a newer recognized, but probably not new. It must have been for a long time. It's just that we got smart now. It's called Pythium Keratitis. It is not a fungi. It is like a fungi, but it doesn't die with antifungals. And this bug is extremely resistant to any antifungal. It just keeps on spreading. The way to make out is that there can be a guttering for this particular lesion. And often they have these more reticular, it's called peripheral tentacle-like extensions. So in a patient who has a very rapid history of progression and is using antifungals the way they're supposed to use every 1 hourly, but actually gets worse. So perhaps you're looking at a case of Pythium keratitis, like in this patient. So the protocol for fungal keratitis is natamycin. Natamycin is the drug of choice for all cases that has been established by the study from Arvind group by Dr. Prajna et al. And voriconazole, yes, it can be used more for aspergillus cases and for yeast, but in all cases, you'll never go wrong if you start natamycin. On the other, and also you can use oral antifungal agents when in certain indications. But the treatment for Pythium is totally different. You need an antibiotic called linezolid, topical azithromycin, again an antibiotic, as well as oral azithromycin. So this is what will work. And earlier we used to have devastating kind of spread of the infection. Now we're able to control it very well. So just a brief table showing you what could be the various organisms apart from fungus that can cause delayed onset infection. So these include a whole bunch of them, like nocardia, atypical mycobacterium. Virus is frequently seen by us. And I talked about, I'm coming to Cantabeeba and Microscodia. And then there could be the non-infectious bunch, like foreign body falling in the eye. So granuloma forms. Bee sting injury we see fairly frequently. Many of us must have seen at least one. Drug toxicity, and due to allergy and VKC, you can have a shield ulcer. So these are non-infectious entities. So how do you diagnose them? Based on the pattern, I explained about Pythium keratitis. We talked about fungal keratitis. You can have nocardia, which has a wreath-like infiltrate, and there would be history of trauma. And then you can also have Microscodia, which is a very weird organism. It's a parasite. It stays in the cornea for very, very long. The long history, waxing and waning, etc. So these are some of the rare organisms we should know about, because though I say rare, you might still see them. So the unusual or rare infections, to show you the clinical photographs, is a case of Cantabeeba Keratitis like this. So you may have not necessarily have a ring-shaped ulcer, but you will have this grayish looking infiltrate, very weird looking. It doesn't look like fungus. And then you should think about Cantabeeba when you see such patients. So this is, you need to do microbiology to establish it's Cantabeeba. You can't start empirical treatment, and you will see the Cantabeeba cysts, which are beautifully seen on this KOH calcoflow white preparation, or even in gram stain. So talking about conjunctivitis, one, I thought that Rajesh may talk about Microscodia. I missed it if he did, but microsporidial organism has been reported to cause both keratoconjunctivitis with multiple such small little lesions present on the cornea, on the epithelial area. And it looks like adenoviral, but it is different from adenoviral. So the treatment for that is either you can just debride the lesions and use some antibiotic as prophylaxis, or even if you don't do anything, these will go away. So that is about microsporidial keratoconjunctivitis, seen much better in fluorescein. On the other hand, microsporidial stromal keratitis. So these kind of patients have this lesion for years together. I had a patient who had this for at least 3 years. So waxing and waning, increases and decreases. Sometimes you think that it may be fungus, sometimes you think it may be nocardia, and various differential diagnosis, or HSV also. And the only way out is to do a corneal transplant. So again, this we cannot treat on our own. We cannot do empirical therapy for this patient. And nocardia has this wreath-like nodular lesions, which is nothing but when you scrape it, you'll see it's an actinomycetes kind of bacteria. It responds very well to amikacin. Same with atypical mycobacteria. It also responds to amikacin, fortified amikacin. HSV can present in many, many ways, and we must think of this organism when the patient's eye looks very affected, but the patient doesn't seem to be that uncomfortable, and that's because of the neurotrophy. So you have a patient able to cooperate very well on the slit lamp, but the cornea looks extremely badly infiltrated. So that may be a sign that you're looking at HSV. So HSV can present either as epithelial keratopathy. Sometimes it's a little hard to make out because it may be a geographic ulcer, especially if steroids have been used. On the other hand, when you have destruction of the stroma, it's called as necrotizing stromal keratitis. The difference being that the epithelial version is likely to respond very well just to topical treatment, whereas the necrotizing version does require oral antivirals and topical steroids and may keep coming back again and again. So coming to the last part of this particular talk is about non-infectious keratitis, what we must know or ought to know. So this is a patient who we had performed a transplant for him maybe 2 years ago, and he was doing well. He was following up locally in another place. And till about 20 days back, when he said that he had sudden onset of symptoms, or maybe 30 days back, sudden onset of symptoms, he came just 2 days back to us for a check. And he was diagnosed by the local ophthalmologist as having infectious keratitis, and see what all he's using. So he has actually stepped down this treatment. He's on antibiotic, antifungal, as well as 2 anti-glaucoma medications. And also, this is the tapering down. He's also on lubricants. We were discussing, do you really need lubricants? He's also on lubricants and Combigan and so on. So there's a very angry looking eye. In fact, even if you look at the lid, the edge of it is very angry looking. And this is nothing but a case of, yes, there must have been an infection to start with, but now it is not getting better simply because of drug toxicity. So what we must know is that if you're going to throw everything at the patient's eye, there will be, it will actually impede the healing of the ulcer. Even if we are on the right track, because of the drug toxicity, we will not achieve resolution of that for that patient. So we stopped everything. We did, of course, take some scrapings to see if there's any residual infection. There wasn't. And we're just continuing this patient on lubricants and homide and watching the patient. He's already getting better 2 days after stopping all the other treatment. And for the glaucoma, which he has, we're managing him with oral medication. So what we need to do is appropriately reduce the frequency and eventually stop all fortified antibiotics for patients after a particular point in time. Despite all of this, if our patient doesn't improve, this particular case, for example, we might have to do a tarsography or an amniotic membrane to facilitate the healing. One more entity I'll just very briefly discuss because it comes under keratitis, but it's not infectious, is peripheral ulcerative keratitis. So you can have patients coming in with this peripheral ulceration, and so much so that there's perforation and iris is plugging it here. This patient underwent a patch graft for that lesion. It was Murren's ulcer. You can have a patient with very advanced Murren's ulcer like this with peripheral panels already, where the disease is burning out and centrally very active. Or you can have a patient who has peripheral ulcerative keratitis, but also the sclera is equally involved. So this is a patient scleritis with PUK. So this is the non-infectious but immune-mediated causes. So what is PUK? It's rare, luckily. It can be associated with systemic diseases, and nearly half of them have collagen vascular disease associations such as rheumatoid arthritis or GPA or any of these vasculitis. And the patient might come to us first. So the initial manifestation could be ocular. So that's the importance of ought to know. We should know about these entities so that we can guide the patient to the appropriate specialist. So that's all I had for today.